Welcome back to Face the State. I'm Arianna Bennett. Thanks for keeping it here. Well, 5 years ago, a major drug bust in Reno turned the spotlight to opioid abuse in our community and all the dangers that come with it. Now, we're seeing a lot of changes when it comes to how these drugs are prescribed and used, along with an increase in alternatives. So board-certified pain specialist Dr. Nairizi is here with me to talk about that. Dr. Nairizi, great to have you on the show.
Thank you so much, Arianna, for having me.
Okay, so we're talking about United Pain Urgent Care. You founded this just a couple of months ago. Tell me how it works.
So it's been an interesting work for us. This is a project worth of actually 2 years work with consulting companies and community leaders, legislature, just to find what the issues are and how we can help something that not for our community, but also beyond our community can help many other people. Just to have a model can fit into the healthcare system to help. And what we looked at, what the issues are. So we looked at from years of experience that many people had in the communities, and myself practicing as a pain specialist, been in Reno over 7.5 years to learn more about the issues. So what currently we do in our Reno Pain Associate was a practice for chronic pain issues. So we see many of these patients, they come on opioids. So we try to give them the alternatives of treatments, the different modalities that we have. And the beauty is the technologies are changing so fast to come to help us to offer alternative treatments for what we did not have before. From even minimally invasive treatments to even sometimes the different type of medications to help the patients. But sometimes it's hard when the patient been on the chronic opioids for many years. To change sometimes, it's still, we work hard, but the mindset and the issues they have dealt with, complications associated with it. Then when we ask when they started getting this medication, why they went on, we realized that when the acute injury happened, they did not have right tools or right treatments, or their access to the treatments beyond the opioid was limited. So then we said, okay, is there an issue that we can address? What we can do to help beyond what we are doing? So the treatments we do, it's great for chronic, but why not just move it into more acute setting when the problem happens? So you look at the national, basically the data for opioid problem misuse. Majority of the time we realize that the time that the opioid is being prescribed in first place is the one of the biggest risk factor for the patient to misuse abuse. So if you have an option in first place when the injury happens, or if the surgery is going to be done for the patient, not to give that opioid or minimize to use, then you have a good chance to prevent that from happening. So we look at the number as every prescription of the opioids, that studies have shown that every prescription of the opioid can increase the risk of misuse abuse by 44%. And each additional refill or each additional week of opioid use can increase that to 20%. So this is the initial phase. What are the options we have? Basically what we have done so far, it was a great, tremendous help by the community and also legislature to come up, for example, with Assembly Bill 474 to address some of the opioid regulation and education. Now we educated so many patients and providers how to prescribe. But just to give you an analogy, taking opioid is like taking bad or eating bad food, unhealthy food, right? If your diet is full of unhealthy food, it's not good for your body, right? But what will you do? You just introduce to education or regulation for diet. So let's just, take that unhealthy food away and replace with something else. Or here, sometimes that we need we don't give you that kind of unhealthy food. But at the end, you have to introduce alternative. We have to introduce healthy food. When it comes to the opioid, when we regulate, that's the right thing. When we educate, it's the right thing. But also, we have to be able to give the patients alternative to treat. We have to make sure that this treatment is also accessible for the patients, because we still have a problem in rural areas, right? We don't have the time to get to that. areas to treat. So then we came up with a plan, what can be done. So the United Pain Urgent Care was basically an answer to some of these issues in acute setting. We realized that when injury happens, a simple example, a back spasm. It shouldn't have to be something very extensive. It shouldn't have been, or it shouldn't be a major injury. Just the back spasm that happens to many people. They have it for maybe a week, 2 weeks, and then it goes away. It comes back. Has happened to many of my friends and family that I do see. Just talk to them and see in the current environment what options they have when that happens.
So what options do they have? I'm curious for personal reasons too. If, instead of prescribing a strong painkiller like an opioid, which is kind of what tends to happen, what are the alternatives?
So currently what they do, they call their sometimes primary care physicians, oh, I'm in so much pain, and said, oh, you can't come in. We need to make an appointment. That put them in like a week out, or maybe just call in some medication to their house. Again, it's a medication, muscle relaxation, or maybe some anti-inflammatory or opioid, or a situation they want to go to emergency rooms. Emergency rooms are emergency rooms basically for more life-threatening conditions, right? You go there. So when it comes to the back spasm, you sit hours and hours, because the priority and the right thing to do for the patient who are suffering from life-threatening conditions, they need to be treated. Right. When it got there, they same thing, maybe just get an imaging, get some of the pain medication, and then they send them back, okay, follow with your specialist or follow with your primary care physician. Again, there's not much of treatment beside the medication. Or the urgent care, it's a normal, typical urgent care. You may go for sore throat, it's the same thing. They give you pain medication or maybe some muscle relaxation. They can't address the acute pain right there. But if it comes to us, that's what we propose. So why not? Because look at the data, look at the evidence. If you introduce the opioid in a situation that you don't have to, then you may decrease the opioid problem, misuse and abuse down the road. So that's a key component. Plus, to treat the patient with the right treatment option. So they walk into the United Pain Urgent Care. Then they get evaluated. So we have an imaging center, we do x-rays. We do have a group of radiologists, thanks to digital health, because it's a cloud-based. We do have a great x-ray technicians that take the imaging, and the imaging gets sent to the cloud, and the radiologists in Texas, for example, or anywhere else in the United States, they review the imaging with the information that they get from us. Then the interpretation comes back to us, so we'll make a decision, okay, if this is, for example, fracture, dislocation, or anything else, there's a muscular issue, then we can address. Then we go with the treatment option for them. So the treatment comes from simple, can be a muscle injection, we get trigger point. That's simple, that not, just easy to do. Or it can go into, for example, that might be their sacroiliac joints involved with the pain in the back. Then it can be SI joint injection when the injury happens. And it can be simple, like a facet injection, part of their spine. Very simple epidural injection on the time that the injury happens. Not a back pain, but these are the treatments that cannot be offered anywhere else they go, because they don't have the people who are trained, ready to go for that. So that's why we have the place designed for that type of treatment in more acute setting, which currently does not exist in the United States. So we are the first and the only pain urgent care to address the acute injuries and acute pain for the patients. Then they can be referred out for further treatments.
This is so interesting, because I think, having had back pain my entire life, that you're describing exactly what I've experienced, which is go to your general practitioner, get a referral to a specialist, then go to the specialist, then they send you somewhere else for imaging, and meanwhile you're in agony dealing with it the whole time, and then what they do give you is a bottle of pills, which, very addictive. Are there other risk factors involved with opioids other than just, they're extremely addictive?
The risk factors, yes, because part of the mental health. So sometimes what we look at into the patients who do have sometimes anxiety and depression, the presentation can be a pain. So you have to have some insight that to learn more which one the reason. Sometimes when the patient suffer from chronic pain, they become anxious, they become depressed. So if you treat the pain, you treat the depression, anxiety. But sometimes the depression, anxiety presents itself with pain. So if you give them opioid, you're not helping. You make the situation worse because the problem is anxiety, depression. But also what we know that opioid long-term can change some of the hormones. Some of the, for example, testosterone level can go down over time. So the immune system can become weakened because of the long-term opioid. So we have seen not only from being addicted to abuse, but also respiratory problem and death death from opioid. But also we see the metabolic changes can happen, the immune system can compromise. So a lot of other issues that we come across when we see the patient is on long-term opioid use.
So this is bad stuff that you don't really want to be taking unless you don't have any other option. What about, and we don't have to get into this too much, but are you an advocate for medical marijuana for pain management?
At this point, we don't have, the evidence is not clear yet, because it's the part that it's very, I think we need more studies to be done, but the problem is because at the national level, is not approved yet. So not many people or not even pharmaceutical companies will invest so much into randomized clinical trial studies to look for efficacy of treatment, because we don't have any agreement yet for the use of medical marijuana. People, but anecdotally, some people, they said it's effective, some they said it's not, but we've seen some result with more anxiety related. We see some people for cancer patient, they have used for nausea related or for problem with appetite. They may take that. We're not clear yet where we go with use of medical marijuana for pain-related issues.
All right. Well, we have just about a minute left. Really quick. So where is your urgent care? Where can people find it?
It's on McCarran, 6522 South McCarran, Suite A. It's right on that South McCarran. And it's open 7 days a week from 8 to 7 p.m. And we're there just to address any of injuries from simple fractures to back pain and migraine headache. They're all treatments that we can offer them interventionally. So hopefully they don't have to use opioid, or at least decrease the use of opioid and get the right treatment.
So go there just like you would any other urgent care, huh?
That's correct. No appointment needed.
Okay. Any final message before we go to break? We have about 30
No,
seconds.
I think we have a great work to do still to learn more and how we can make it better, and hopefully we can see more and more support from community leaders, from insurance companies behind the project, because I believe it's the right thing for our community and also it's the right thing for the rest of the country.
All right, Dr. Nairizi, thank you so much for your time.
Thank you so much for having me. Thanks.
All right, that's it for this episode of Face the State, but for more information or to see past episodes, you can head to our website, ktvn.com. Thank you so much for being with us. We'll see you next week.